Okay, so now I'm going to hand over. Now we're going to have our panel discussion. And Khursheed Wadia, Dr. Khursheed Wadia actually, is going to be chairing this session. She's our trustee. She's been there since 2011. So that's nearly 10 years, Khursheed, which means that 10-year anniversary is coming, which means another party, really. We just needed excuses to celebrate, don't we, really? And Khursheed is also an associate professor at the University of Warwick, and she will be hosting the panel discussion on addressing the needs of Muslim women post-COVID. So over to you, Khursheed.
Thanks very much, Shaista, and it's really good to see so many of you here today. I'm going to start off now because of time. So this year we thought that given the entirely abnormal situation in which we find ourselves, in which the whole world finds itself, that it would be impossible to ignore this public health crisis that has been created by COVID-19, not only because of the levels of ill health that it's created, but also because of its devastating impacts that we see around us in the social, economic, and cultural spheres of our collective life. And also the bind into which it has placed political decision makers and those who implement policy. One of the most glaring facts which political decision makers have been unwilling to face with urgency is that women the world over have been the hardest hit of populations in this crisis. And in fact, only yesterday, a BBC report noted, and this is really truly alarming, that according to new global data from the UN, I quote, "The coronavirus pandemic could wipe out 25 years of increasing gender equality. So we have 4 interventions today, and our panelists are going to try and unpack some of the impacts of COVID-19 on women in the UK, and particularly on Muslim women in the UK. So these interventions are from our trustees, and they reflect both the personal and the professional interest in gender equality generally, but also in the health and well-being of women from Muslim communities more specifically. So in the order of moving from the general to the specific, we're going to kick off with our trustee, Sophie Garner, who asks how the COVID-19 crisis has worsened gender equality in the UK, while Dr. Iram Sattar will assess to what extent the mental health needs of Muslim women are being met in coronavirus times. And then Iram will be followed by Shaista, whose concern is whether the spotlight cast by COVID-19 will push those planning and managing our maternity care services in the UK to finally address the historically poor outcomes that have been there for Muslim women within these services. And then finally, the 4th of our panelists is Nazmin, and Nazmin's question is why Bangladeshi communities among UK minority communities put together have suffered the worst health impacts of the coronavirus. So having given you that overview of what's coming, I'll hand over now to Sophie. I'll just say a couple of words, a couple of sentences about Sophie. Sophie joined MWNUK in 2016. She's a barrister and a mediator, and she specializes in employment and discrimination law, practicing from Birmingham. So alongside her legal career, over 25 years, Sophie's also developed a parallel career in the voluntary sector, during which time she's undertaken a variety of roles, the role of trustee, chair, treasurer, and also company secretary. And just to remind you again, Sophie's talk is titled, "How is Gender Inequality Deepening During COVID-19?" So Sophie, I'll hand over to you right now.
Okay, thanks very much, Khursheed. I was interested to hear the statistic from the UN about it being a 25-year gain that's now being dropped off. I've been working on discrimination cases probably for about 25 years. And certainly I know that the first 15 years were a very slow climb up towards the Equality Act. I was a trustee of the Discrimination Law Association when the Act was in its consultation phases. And it was pretty much a gargantuan task to mould all the different strands of legislation to do with the different protected characteristics into one act. It was really an achievement. But unfortunately, in my view, being at the coalface on these sorts of cases, that was pretty much the high point. Since then, it seems to me that the rights of people who should have been being protected under the Act, people from non-white races, from women, from various religious groups, the rights of these people have been going pretty much downhill. And that's through a succession of governments of all colours, from Labour through the coalition through to the Conservatives now. What's really worrying is that with COVID and with the economic fallout from Brexit, we're not just going downhill, we're pretty much going to be falling off the edge of a cliff in terms of women's rights, unless we all stand up and do something about it now. So starting with the workplace, the majority of my cases deal with women in the workplace. What's happening here? Well, where do women work? Predominantly, women, including Muslim women, work in lower paid sectors such as hospitality, retail, and as carers, and in the NHS. And what's happening in those sectors at the moment? Well, hospitality and retail, many of those positions have been furloughed. The ONS published statistics last week stating that 1 in 3 of UK hospitality firms fear that they're in danger of collapsing shortly after Christmas because of COVID-related lockdowns. And that's, of course, much more severe in places where they have been in tier 3, and that covers a large number of areas where there are large populations from ethnically diverse backgrounds. Women are more likely to be furloughed, and the whole problem with that is out of sight, out of mind. And so when it comes to making what are going to be the inevitable redundancies as soon as the furlough payments cease, it's going to be women who are going to be falling victim in greater percentages. And that becomes worse if the women are pregnant or have children, mothers of young children. And that was backed up by a Fawcett's study, which was published last week. And of course, even today, we've had the announcement that Arcadia are probably going to go down as well. That's a retail company with approximately 13,000, I think, roles, majority of which are likely to be held by women. So what about carers in the NHS? These jobs at least are stable, but the problem is that within those professions, you're far more likely to be the victim of COVID yourself, not just catching it, but potentially from dying. And as well, that's something that happens to people from ethnic backgrounds, from non-white ethnic backgrounds in increasing numbers. And I know that Nazmin is going to be looking at potential reasons for that in her talk. And then we come on to pay. How much money do women get for their work? Well, we've just passed Equal Pay Day, the day upon which, after which all women are working apparently for free, or a large number of us are working for free. Hooray, because of the gender pay gap between men and women. And with the economy due to contract by 11.3% in the next year, we know it will be women's roles will be the first to see pay freezes, especially in the public care sector. And I think Rishi Sunak confirmed this week that there'll be no increases, pay increases for those in the public care sector. And of course, the problem is for women of colour, it's worse. All statistics routinely show now that right at the bottom of the pile in terms of pay audits sit non-white women. And that situation doesn't appear to be improving at all. If anything, it's getting worse. The good news is that the campaign for requiring race pay disparity statistics to be published, as well as gender pay statistics, is gathering pace. Both Fawcett and Women's Equality Party are both currently having big initiatives to push for that. And of course, this is undoubtedly because the other glimmer of hope from 2020, although obviously born of a tragedy, the BLM movement, the good news is that that doesn't appear to be running out of steam. It appears to be that those voices are going to be getting ever stronger. And that's something that we really need to work on with ourselves. But what about discrimination areas other than work? Well, multiple studies have shown that in times of crisis or concern, individual preferences produced and strengthened by group-based identities operate to shape attitudes to inequality and lead to an increase in discriminatory acts. Fear of infectious diseases is also associated with irrational economic and social responses, such as increased xenophobia, as well as panic buying of toilet roll. So in the current climate, where there have been recent acts of terrorism and related increases of reported hate crime, the impact is only going to get stronger. Of course, the other element of harassment, which I know other speakers are going to be dealing with, is the increase in domestic violence and harassment within the home, which of course has suffered dreadfully during COVID. But what about those with no formal job? The vast majority of, I was going to say the vast majority, an awful lot of women still carry out the majority of unpaid housework, childcare and elder care, and often this includes an element that could be described as healthcare as well. And it's perhaps more so in families such as many Muslim households, where traditional roles can be reinforced and there's a greater emphasis on caring for elderly relatives within the home. But what we need to wake up to, and this is my personal opinion, is the fact that this work has a value, and we need to demand respect for those amongst us who are not deemed to be economically active, but who do a huge amount of unpaid work. Researchers for UN Women have found that unpaid healthcare provided for women amounts to 2.3% of global GDP. That's $1.5 trillion. And that's just the healthcare related free care that women give. If you add in all the childcare and the elder care, that figure goes up to $11 trillion worth of unpaid contributions that women are making to economies around the world. And so far as I'm concerned, we have to be working together with other organisations to repeat the statistics and say that enough is enough. We know that women and women of colour are bearing the brunt of the social, economic and domestic damage that has been done by this virus. And MWN are part of this movement, not just to complain about it, but to come to the table with real statistics and information from our research, which we deem to be so important in what we do. And we're not working to empower we're working to empower Muslim women to recognise their own rights, including their right not to be discriminated against, but perhaps more importantly, we're helping them to recognise their own value and to demand that they get that same recognition from others. Thank you.
Thanks very much, Sophie. That was really, really interesting, and it's given us a real good summary of what's been happening since the Equality Act was implemented. The Equality Act 2010 was implemented. I'm going to just pick out some highlights, if you like, from Sophie's talk, which you may find are points that you want to look at in terms of posing your questions at the end. So one of the things that Sophie said was that, and this kind of underpinned her presentation, was that since the Equality Act 2010 was implemented, equalities have actually not been advanced, but that inequalities have deepened in our public life. And it's the disadvantaged groups and the underrepresented groups that are most affected by those by that erosion. The other thing that Sophie mentioned is that, and it's an alarming thought, that our economy is forecasted to contract by 11.3% next year. And of course, those who are going to bear the greatest brunt of this contraction will be women in the most precarious sectors of work, and the ones that Sophie highlighted were the NHS, the care industry, retail and hospitality. The other factors that have been challenges to the Equality Act 2010 are the hardening attitudes of people generally, of the majority population, against people from racialized minority. Those attitudes have hardened in the wake of terrorist attacks that have taken place over the last couple of decades, and has led to a rise in Islamophobia, racism, xenophobia. But the upbeat part of that intervention was that there is hope, that we do have social movements who are pushing back. For example, Black Lives Matters, and amongst those social movements, Muslim Women's Network is taking a central place and hopefully leading in that pushback against the hardening of attitudes and deepening disadvantages. Okay, I'm now going to pass over to Dr. Iram Sattar. She joined MWNUK in 2009 as a board member and is our current treasurer, as you heard before. Iram's a GP with a keen interest in health inequalities, and particularly in the area of mental health. And she's helped to set up innovative ways of treating mental health patients in the community. So over the last couple of years, she's delivered mental health awareness raising workshops to local women in Wandsworth. And these have been very well received and praised. And today, Iram is asking, are the mental health needs of Muslim women being met? Iram, it's over to you.
Thank you, Khursheed. So like Khursheed just said, I've been asked to talk about the impact of COVID-19 on the mental health needs of Muslim women. So I'm going to split my kind of talk into three parts. What is the mental health impact of COVID generally? What is it specifically for the Muslim community and Muslim women? And then I'll talk about meeting the mental health needs of Muslim women. So if we look at the impact that COVID-19 has had on our mental health, I mean, we've all lived through the pandemic and we know only too well the stresses it's placed on us, our families and our communities, such as increased isolation and loneliness, especially for those living alone or those who were shielding, uncertainty and fears around jobs, finances, housing, catching COVID, getting ill with it, and even maybe dying from it. Schools being closed and the effect that had on children and their learning and their development, and also on parents who were expected to be full-time workers as well as full-time parents and educators. And then death, you know, when we've lost a loved one, we've not been able to grieve collectively. This hit home for me because my dad, his brother, passed away during the first lockdown in Pakistan, and he wasn't able to go and take part in the funeral. He wasn't able to meet with his family and have that grieving that you need to do with you know, loved ones. And so all these things and all the effects of it are going to be almost like post-traumatic effects for months and years ahead. And also on top of that, there was a delay in seeking help. So when you delay seeking help, this means that mental health problems get worse and more complex. And the delay was due to, especially in the first lockdown, because people didn't want to burden the NHS, so they didn't come, or they thought they wanted to avoid catching COVID, so they didn't try and get help. Or they didn't realize services were open, such as GPs, counseling services, hospitals. You know, remote consultations was implemented pretty quickly. You know, for us, it was the same day it was implemented. So that's the kind of general mental health effects. And now I'm going to talk about the effects on women and Muslim women. So Sophie's already kind of talked about this and the gendered effects, but just to kind of recap a few points. So women, they work in sectors that are most affected by job losses, such as restaurants, travel industry, retail shops, because these jobs can't be done remotely. Then you've got childcare issues. So this has meant that women have had to give up their jobs to look after the children, especially if they weren't the main earner. So this means that low-paid, young, working-class women are hit the hardest. And if both parents are working from home, then who do you think is expected to look after the children, especially in Muslim households? And then finally, if we think about domestic abuse, you know, we've all heard about how calls to DV helplines went up in lockdown. And obviously, this is not surprising, given the fact that you're in lockdown in a house with your abuser. There's no respite or time away. You can't go out to pick the children from school if the schools are closed. And then you're unable to even get help or speak to someone, because if you try to call someone or speak to your GP remotely, it's not private. They can, you know, your abuser can hear what you're saying, so it's harder. So I think we can safely conclude that that epidemics have gendered effects. And then now I'll move on to the impact of COVID on Muslims and ethnic minority groups. So at the beginning of the pandemic, I remember hearing again and again, COVID is a great leveler. Anyone can catch it and anyone can be affected. But as time has gone on, the inequalities and disparities in health have become only too apparent. So I'll give you some stats from the Race Disparity Unit, the government's own Race Disparity Unit. 34% of all critically ill COVID patients were from our ethnic minority group. So this, in the census for 2011, ethnic minorities made up 13% of the population. So that's almost a triple increase. Ethnic minority groups are more likely to be key workers, so they can't work from home, and therefore they're exposed to COVID. They're more likely to live in urban areas where transmission rates of COVID are higher, and they're likely to have less living space, which means they can't socially distance and self-isolate. And there's another report that was launched in October from the Runnymede Trust and the Institute for Public Policy Research. And this found that the infection rates in Pakistani communities was 4 times higher than white communities. And it also highlighted that men and women from all ethnic groups, so this is Black African, Black Caribbean, Pakistani, Bangladeshi, all apart from Chinese women, had a greater risk of death. For women, it was nearly twice as likely, and for men, it was more than twice as likely. So to put this into context, what the report said was they estimated that over 2,500 deaths could have been avoided during the first wave if Black and South Asian populations did not experience an extra risk of death compared to white communities. So, why do they have this increased risk? And, we hear time and time again, oh, it's diseases like diabetes and heart disease and lung disease. But actually, these don't explain all the inequalities or differences in death rates. And even when you look at things like diseases and deprivation and you account for them, still there's a large amount of unexplained risk. I'm just going to share a slide with you. I hope this works. Okay, so you can see, can you all see my slide? Yeah, okay, so let me just get rid of that. Okay, so what this slide shows, so I'm going to see if I can use, can you see my arrow?
Mm-hmm.
Yeah, great, okay. So what this slide shows, if you look at deprivation and you correct for deprivation, then yes, there is a little bit of increase due to that in South Asian and Black communities. If you look at comorbidities, such as diseases, diabetes, etc., actually being South Asian is a little bit better. And being Black is a little bit worse. So this is the big problem. This increase in risk. So these are deaths, by the way. This increase in risk is unexplained. So I'm just going to remove that now. There we go. And some, commentators have said it's due to genetic differences, but the evidence is clear. There is no genetic basis for race or ethnicity. Genetics doesn't decide which houses we live in or which jobs we do. Instead, this inequality is likely to be driven by structural and institutional racism that results in differences in social conditions such as occupation and housing, and also experiences of discrimination and distrust in NHS services, which lead to a reluctance to seek care on a timely basis. So in conclusion, if you take the mental health effects of the pandemic, then you add being a woman and the gendered effects, then you add to that being from a minority ethnic group and the resulting health inequalities, it's easy to see the layers and layers of impact on Muslim women from COVID. And now I'm going to talk about the meeting the mental health needs of Muslim women during COVID. The first question to ask is, were the mental health needs of Muslim women being met before COVID? But the answer is unfortunately not. So we know that Muslims may be less likely to recognize mental illness and access help because they may see it, beliefs such as they may see it as a test or a punishment from God, or as God's will, or as a weakness in their faith. And this is common for other religious communities. Also, the language for mental health symptoms is minimal in Asian languages or not other languages. And also there's a thing about believing in black magic or evil eye or jinn possession. So there are some reports that the mental health problems are 60% higher in minority ethnic groups. And for Muslim women, you've got the additional pressures of tradition, honor, patriarchy, marriage, and language barriers. There was a study done in the UK of Pakistani women about mental health problems. And it found that they were less likely to go to the doctor. If they went, they were less likely to be diagnosed and treated. And if they were treated, it was less likely that the treatment would work. So why is this? Less likely to go to the doctor? I've already explained why they may not present, first of all. And then why don't they get diagnosed and treated? Well, they may attend with their husband or with a child who might be there to interpret. And therefore you can't really speak freely about your issues. And they are probably less likely to be demanding and ask and advocate for themselves. So they're easier to fob off and not refer or do good service for. And why is the treatment less likely to work? Well, we often get told this on our helpline. With mental health, counselling is a really important part of treatment. Drugs work, but counselling is really, really important. Talking therapy is really important. And they often say that the service they can't relate to the therapist because the service isn't faith and culturally sensitive. And then there's language barriers. And even if you have an interpreter in the room, can you imagine having to talk about your innermost feelings and thoughts, not in front of one person, but in front of two people? So that's actually a barrier, even if you have an interpreter in the room. So finally, how can we improve mental health services and outcomes for Muslims and Muslim women? So the foremost thing is having faith and culturally sensitive healthcare services. We also need to raise awareness and do outreach work into Muslim communities. And we need to address their spiritual needs. Now, spirituality is a really important factor when it comes to recovery and resilience, especially in mental health problems, and especially in Asian and Black minority ethnic groups. And then we need to design services with service users rather than for them. And this is so that they can input to improve their experience. This is to build trust and to increase access for minority ethnic communities. There also needs to be economic support and stimulus for women during and after the pandemic to address the economic fallout for women. We need better childcare provision, and employers need to be flexible. So the Chancellor recently announced an extra 500 million package to support mental health services in England. And I hope that this money is spent in a way that decreases the inequalities in health faced by ethnic minorities, because racial inequalities are a stain on our claim to be a civilized society. Over to you, Khursheed.
Thanks very much, Iram. I'm not going to say a whole lot here because we've got time not on our side. But one of the things that struck from your talk was that women from racialized minorities were twice as likely to die as white women from COVID-19, that diseases such as diabetes, etc., cannot account for the high deaths, so that there must be other factors to be looked at, that those factors are structural, those factors are attitudinal, which lead to prejudice and racism, and that there are many layers of factors which impact on the poor outcomes in mental health for women from Muslim communities. You've suggested a number of ways in which this can be improved, in which treatments can be improved, in which the material conditions of Muslim women can be improved. And I'll leave that to the audience to kind of go into much further later on. So our third speaker today is Shaista Gohir OBE. Many of you know Shaista very well, I'm sure. Because she's a highly influential activist. And in 2020, Shaista was appointed as the Women's Voices Lead at the Royal College of Obstetricians and Gynecologists. And I'm sure that in her role, she is going to ensure that women's voices, and particularly Muslim women's voices, are heard at all levels, and that their experiences are going to be used to strengthen policy and practice across the board for women. So Shaista is asking, will poor maternity outcomes for Muslim women finally be addressed? Over to you, Shaista.
Hello again. So yes, I will be talking about Muslim women's poorer maternity outcomes, because what the pandemic did is highlight those differential outcomes again for actually Black, Asian and minority ethnic women. But before I kind of proceed, I just want to quickly address what's been sort of talked about in the chat. Which is this terminology about BAME, and Khursheed used the words racialized minorities, and someone else said women of color. And in fact, because of this, I'm going to use the term BAME for the rest of the talk. We are going to do a survey. Muslim Women's Network have prepared a survey with different terminologies, because we recognize the fact that there has been debate and discussion on this. And, you know, just because women of colour has been now popularised, for example, on social media, that doesn't mean everybody likes it or it's the right terminology. So therefore, we are going to put a survey out next week. I'm going to borrow Boris Johnson's term. It's oven ready, but ours is literally oven ready. It will go out next week. So please participate in that survey and share the views that you're sharing here. Share them. So we'll send that to you probably, you know, early next week. So back to my talk. During the COVID pandemic, when we looked at the pregnant women hospital admissions, 50% of those were from Black, Asian and minority ethnic backgrounds, and Black women were higher in that proportion. So, you know, why is that? We need to sort of ask that question, yet BAME communities are making up 13% of the UK's population. So there's a difference there. But already we knew the statistics anyway, for the statistics have been around for like 20 years of poor outcomes. So Black women are 4 to 5 times more likely to die in childbirth and the postpartum period, particularly that period just after childbirth. And South Asian women are 2 to 3 times more likely to die. But over the last 20 years, the needle has gone in the wrong way. It's actually gone worse. So we've got to ask ourselves, if report and keep coming out, why is this issue getting worse and not being addressed? To me, it's clear that women's experiences are not being heard. No one's asking them, well, actually, what was your experience during the, you know, antenatal period, during childbirth, during the delivery period, and then the aftercare as well? Because that would then probably give you some clues as to what might be happening. I just want to read some sort of facts, and these are drawn from statistics. And then there will be probably more detailed report coming out, because there's all these audits of statistics that are done from hospitals. But this will give you a clue of why women are more likely to die. So Black and Asian women are more likely to enter pregnancy unwell, with conditions or develop conditions during pregnancy. South Asian women are more likely to have an instrumental birth. The rates of emergency cesarean are higher amongst Black women than South Asian women. Black women are more likely to have postpartum hemorrhage, that's blood loss, then after that it is South Asian women. South Asian women are more likely to have higher admission due to hypoglycemia due to gestational diabetes. Now let's look at sort of the baby outcomes. That was sort of the mother's outcomes. Neonatal mortality rates remain higher for you know, babies born to Black and Asian women. Preterm birth is higher amongst Black women than it's South Asian women. And then the admission rates for newborn Black babies is higher than it's South Asian babies. So you can just see there that you can just look at those statistics and think, well, you know, the deaths can probably be related to that, but actually it does seem to me deaths are preventable with good care, good antenatal care, good care during delivery, good care just after the birth of the child and that period afterwards as well. So why is there a differential? Is it just poor standard care across for all women? But the statistics are telling you otherwise. Is it conscious bias or is it unconscious bias? The only way to find out is talk to the women, find out what their experiences are. Now, I'm glad to say that suddenly lots of bits of research are now being done. So now you are going to have lots of maternity organizations, like charities that are doing the research. There's academics as well. There's hospitals that they're looking at all this data now, and they're going to speak to BAME women. But my sort of concern is, all of this research is not led, is led by sort of not non-BAME led research, which is fine, but I think some research in there needs to be led by BAME organisations, because the outcomes and the recommendations will be very much informed by what is asked in the first place. So what we may ask as Muslim Women's Network may be a little bit different. And I hope other, minority organizations do this research as well. It's impossible for one organization to do all the research. It's really complex. Now that I've been looking at it, I didn't realize how complex it was. So I think it's better that lots of organizations are doing this research and to find out what the experiences are. And now our research is being done, it's actually a part of the All Parliamentary Party group on Muslim women, which was, Pfizer talked about it, launched in October. And this is the first inquiry that's being done. And we're the secretariat, and we are going to be overseeing that research. And Dr. Surya B is actually doing the research, and I'm going to be supervising it. So I think that once we do that research, we are going to not just look at race, but actually faith as well. So when I've been having conversations with different researchers, they keep talking about race, conscious and unconscious bias due to race. No one is talking about faith. And for Muslim women, that discrimination is likely to be intersectional. Discrimination often is. So if we don't consider faith, then there's going to be something missing in the recommendations. And after all, faith is a protected characteristic. So why is it being ignored? So I think when we come out with our findings, whatever they may be, it may well be the same as everybody else's, but surely that's a good thing. Power in numbers, all the organizations going to the clinical commissioning groups, the professional bodies of nurses and doctors and the Department of Health, and it will be a stronger voice. If it's a little bit different, and all the organizations are saying something different, that's good as well. It's a jigsaw, will be a jigsaw, strength in numbers again, and we'll be hopefully collectively we've covered our bases in terms of recommendations to actually change the outcomes and improve care. Now what we plan to do is get a survey out soon in the next sort of probably next couple of weeks. So we really need your help in getting that survey out to as many women as possible. We are also looking to interview between sort of 35 and 40 Muslim women, particularly who have given birth in the last 5 years, who have, we want to find out what their experiences are. I've spoken to a few women, and some are saying my care was really good during the pandemic, and some are saying actually my care was really poor. But actually no one should receive poor care. Nobody should receive poor care. So it might have actually got worse. We know it's worse anyway. It might have got worse in the pandemic. So what I want to really leave you with is really an ask for help. Once we get our research survey questions out there, and we're trying to shorten it, it's a really long survey and it's quite complex, really hard to do a short survey on such an important topic. So the question is, can we make a difference now? That is the key question that I need to address. I think yes. I think if we had done this research a few years ago, the answer would be no. Nobody was willing to listen to us. But now, given that it's really high up on the political agenda, given that lots of organizations are looking at this, they are wanting solutions, they are wanting recommendations. We need to go into that space and make our voice and our perspectives heard. So yes, I do think right now we can make a difference, and hence we are doing this research, and I really need your help.
Thanks, Shaista. Thanks very much for that. What's highlighted by Shaista's talk is that the poor maternity outcomes for Muslim women, which have been there historically, have been particularly highlighted during this COVID pandemic. One of the really shocking statistics that you put forward, Shaista, was that women from minority communities, Black and Asian women, South Asian women in particular, are 4 to 5 times more likely to die in the postpartum period. That is really a shocking statistic. And you also gave some information about the poor outcomes for babies of those mums, and you're asking what the reason is. The reasons hopefully will be found, or some of the reasons will be found in the survey that MWN puts out over the next week or so. And hopefully we can see a response as a result. We can put forward some recommendations as a result of what we find from the survey. The other thing, Shaista, that you said that is really important is the co-designing of services by service professionals in the service with women from minority communities. I think that's a really important takeaway as well, and the audience might want to pick up on those points. Okay, so last but definitely not least, we're going to hand over to our final speaker, who is Nazmin Akthar. Nazmin became co-chair of MWNUK in 2019. Just tell you a little bit about her background. She's a chartered legal executive lawyer specializing in residential development and infrastructure, and works in the real estate department of a leading legal 500 firm in the southeast of England, which acts for key players in the housing industry, including national house builders, housing associations, small developers, and charities. And Nazmin's firm belief is that housing is a human right and is key to tackling abuse and inequalities in all its forms. So Nazmin's talk is titled, "Why are those of Bangladeshi origin at most risk due to COVID-19?" So Nazmin, over to you.
Thank you, Khursheed. Hi, everyone. So as Khursheed said, the question I will be focusing on today is why were Bangladeshis in the UK at an increased risk due to COVID-19? And as a British Bangladeshi myself, this is actually a really personal topic to me. I'm sure we've all heard the facts. People of Bangladeshi ethnicity had around twice the risk of death than those of white British ethnicity. And then if you look at the working age population, which is where I fit into, the increased risk of death is 80% higher. So according to Public Health England, what I was hearing earlier this year was that I am 80% more likely to die than someone of white British origin. Was I scared hearing this? Absolutely. I was so scared, but was I surprised? No. And sadly, that's because I knew that deep down, this wasn't about genetics, it was about inequalities. My fellow trustees today have already shared with you some of the key reasons for these disparities in outcomes: pre-existing health conditions, mental health issues, the fact that those from BME groups are more likely to work in occupations with a higher risk to COVID-19 exposure, or, if I can be more precise about it, low-paid jobs where they're struggling to make ends meet at the end of the month, especially when you're a BAME woman. And another reason that Public Health England then highlighted was actually living conditions. So it wasn't just health conditions as we have discussed already, but housing challenges as well. According to Public Health England, COVID-19 risks are increased by housing challenges such as overcrowding. In London alone, 30% of Bangladeshi households have more residents than rooms, compared with only 2% of white British households. Living in intergenerational households with parents, grandparents, grandchildren is another reason, as those of working age would leave the home, most probably to go to their low-paid jobs, and then may contract and spread the virus to the elders in their household, and we're then in the cycle where they're trapped in the cycle that they just can't get out of. Now, before anyone says this is a cultural issue and a problem within the communities, let me share with you another reason that in the Public Health England report, and that's housing insecurity. So what they were essentially saying is that a lack of secure, good quality, long-term housing also increased risks of COVID-19 deaths within the Bangladeshi communities, as well as other BAME groups, of course. According to Public Health England, BAME populations are much less likely to be owner-occupiers of their residence compared to white British populations, meaning more often than not, they're renting or living with family or friends. And the relevance of this is obviously because living in overcrowded intergenerational households isn't always about culture or choice or because your family told you to. Sometimes it is simply due to lack of affordability. And the most frustrating part of this finding for us has been that MWNUK have been saying this for years in the context of supporting minoritized communities, especially Muslim women who are at risk of abuse. I don't know how many times we've said that we need more long-term housing, affordable housing, because otherwise Muslim women will be continuously forced to choose between being abused and being homeless. Whenever we get calls on an MWN helpline, homelessness and housing issues are just as relevant when domestic abuse and other forms of abuse are being discussed. We've consistently talked about the safety and mental health needs of Muslim women in the context of housing too. And once again, COVID-19 has highlighted why this is so important. We've explained that what is in the local area matters, that convenient routes to shops and to schools matter, especially for single mums and those with disabilities. We've always known that play areas and open spaces and recreational areas are really, really important for women and children because they need a place where they can play safely, exercise safely, and simply just go and breathe fresh air. Ventilation, sunlight into homes, soundproofing, all of this is all key to good mental health. And we've always known this, and had perhaps if attention had been given to this sooner, then the face of the pandemic may well have been different, and maybe the death numbers within the Bangladeshi communities and the BAME groups overall might have been different. Now, we know there's currently a focus on building more houses, and that's great, and we're really pleased about that, but we really, really need to do more, and soon. From someone who works within the housing industry, I know there's a great commitment all round to address the housing challenge, but we need to focus, we need to work smarter, harder, and look at using better technology, but most importantly, and I think this is what COVID-19 has highlighted, is we need to listen to the lived realities of BAME Muslim women when making decisions about housing, about infrastructure, about residential development. The point of today is to understand how to address the needs of Muslim women in a post-COVID world. And key to this is addressing economic inequalities. That includes addressing pay gaps and also urgently providing more safe, secure, affordable, and habitable housing. We know this won't happen overnight, but it can happen a lot sooner with the right commitment, right strategies, and by involving women, BAME women, Muslim women, in decision-making when it comes to physical and social infrastructure at all levels. And that is my key ask for today, that whilst the housing challenge may take a lot longer, we need to make sure that BAME Muslim women are now already at the front seat, making these decisions in planning departments, in construction, in estate management, everywhere. The pandemic has proven what happens when Muslim women aren't involved in decision making. I'm sure you've all heard the news where the store in Wales decided that tampons weren't essential items for purchasing during the second lockdown. That is what happens when women aren't involved in decision making. And it's really, really crucial that we change the way things are. Iram had mentioned that we need mental health services that are designed and tailored using service users and their opinions. Shaista has also mentioned the importance of listening to women and understanding their experiences to affect change, and housing and addressing issues in the work of employment are exactly the same. We need to speak to BAME women, ensure they're consulted first, and ensure that they are the ones helping shape plans for us to achieve a fit for purpose world. That's all from me, because I think I have actually talked a lot. Thank you. Back to you, Khursheed.
Thanks very much. Again, that was a really interesting and talk with a lot of information that is alarming. Amongst the information that you presented, the figure that 80% more of Bangladeshis are likely to die from COVID-19, that is truly alarming and upsetting, but as you said, not surprising. And in your talk, you focused on housing as an issue and on poor housing conditions, the lack of affordability, and the lack of consultation with Bangladeshi populations, with Muslim women, as being factors which have exacerbated, or which rather have been highlighted by the pandemic, as far as inequalities are concerned, and the way in which they touch Muslim women and Bangladeshi populations in this country during this pandemic. So I think that there's one thing that's come out throughout all of the talks, and that one thing that's come out is the need for consultation with the users, whether they're the minority populations generally, or more specifically Muslim women within those minority populations. It is absolutely crucial that they are involved in policy making and policy implementation. I'm going to hand over now to the audience and to take questions from you, and you can direct them to any of our four panelists. We'll look at them as they come through the chat.
I think, Kat, you had asked a question specifically around furlough and any reference research around it. So I've just pasted in the chat a link to the Fawcett Society report. I don't know, Sophie, do you want to add anything or explain a little around that?
Yeah, no, it was a report from the Fawcett Society last week that was timed to coincide with the Gender Pay Day, and it was looking at all aspects of how women have been impacted upon adversely by COVID. And although it said that I think the problem is that the longer term furlough, there were 1.63 women kept on furlough to 1.5 million men. And it was just, well, what impact is that going to have? They thought that at least as many women as men would be made redundant, and I fear that it will be greater than that, but we'll have to wait and see, because of the nature of the work that women do and the sectors that they work in.
Thank you, Sophie. Does anyone want to add to that?
I actually just want to make it not related to that point. Something that I didn't mention, and I just wanted to link it in with what Iram said, because I talked about maternity outcomes, but one thing I didn't talk about was actually mental health during the pregnancy, and also in that, we know postnatal depression, but how much of it is recognized in Muslim communities. So already we know that statistic out there, the South Asian women are more likely, a higher risk of suicide and self-harm anyway. Then you add to the fact that actually, you've got depression during pregnancy, you've got depression after pregnancy. If that's not recognized, you can then see them having poor outcomes. And I was at a meeting the other day with this role that I've got. And in that meeting, I didn't know about this, but in that the first year after you've given birth, and when someone was doing an analysis of the deaths of women in that first year, the highest reason was suicide, which really shocked me. So I think when we're looking at this issue for Muslim women, we also need to be addressing their needs. If they may be coming into the pregnancy, maybe with depression because of what else is going on in their life, maybe domestic abuse, maybe other issues, or they may develop it during pregnancy. If that is not picked up by healthcare providers and professionals, and then signposting those women, and we're getting some of these calls on the helpline, by the way, then their outcomes will be poorer. This needs to be picked up in their care.
Thank you. We've got another question from Simon O'Neill to all the panelists. Are there any campaigns that Simon and any of his contacts in the football industry can help publicize, in particular to gain wider support? That's really a helpful question. And
well, Simon, if you can help, with any of that, that would be fantastic. In terms of, I think football is, everybody loves football. Male, female, different faiths, ethnicities, social class. So I think you don't like football. I've seen a little way. No, you don't like football. Okay, so And Iram's a Liverpool supporter, so I don't know what, it'd be interesting to see. Actually, in your chat, tell us what football team you support. So I think that would be really helpful. We don't have the links to do that. And I think that would be really useful, especially when it comes to domestic abuse. I think if you could help raise awareness of that, that would be fantastic. Newcastle, Liverpool. I'm Liverpool as well. Liverpool's winning at the moment. I know we're going off topic slightly, but it's fun. I'm going to put Liverpool in there. And by the way, my household sport Arsenal.
So Shaista, I was just going to say, I mean, this is a really good opportunity with 3 minutes left. I know we've had lots of conversations kind of on the chat, but just to really, I mean, what we've done is extended the session by 15 minutes just to allow anyone to stay on and have informal discussions with us. So before I hand back to Khursheed, what I just wanted to say was, for everyone who's joined us today, I would definitely recommend going onto the MWN Hub website. As a new member platform, what we're really trying to do with that space is to give you the platform to raise the issues that you are working on that are important to you. You know, submit an article, submit videos. The idea with the platform is that MWNUK won't be gatekeepers to promotion ultimately, and we really want to make sure that it's utilized. So anyone interested in submitting something, you can get in touch with us. We're happy to speak to you before you submit, and we can help out if we can with editing and things like that. So Khursheed, I'm going to hand over to you.
Okay, have we got any other questions? If you've got any, there's no, I can't see any immediately in the chat box, but if you have some that you want to pitch in with on screen, then please go ahead, put your hand up.
You've got 1 minute before we officially stop and then go to the informal networking.
While people are thinking, I just want to just quickly plug I know the maternity survey isn't ready yet. I know you're probably sick to death of filling in lots of surveys because there's loads of surveys around about all kinds of things. But this survey is going to save lives of mothers and save lives of babies. So this is why we need your help, because if we can make recommendations to save lives, that's going to be fantastic. So we are going to pester you afterwards, you know, in the coming weeks to help us.
Thank you. Shout out for Simon, whose semi-protein Cadbury is going to organize a charity match for MWNUK in the summer. Great news. Yeah, there's a question to Sophie. Right, okay, that's a conversation between Sophie and Kainat. Any other questions?
No, I think that's it. So
I think that's it, yeah.
So thank you everyone for joining us today. I know a lot of you have to jump off the call, but you know I'm sticking around for the next 15 minutes. So I'm going to stop recording, and that will end our event. Thank you.